Thank you. And I would like to start with my disclosures. I have none. And stroke is a huge burden in the society. We have 2 per 1,000 patients per year with stroke in the Western countries. It's the 3rd most common cause of death and the most common cause of disability among adults. There's many complications after a stroke. Some of them experience depression, some develop dementia, some epilepsy, and some chronic pain. So it's a disaster for a patient to have a stroke. We have acute treatments, and those treatments are very effective, but they have to be treated within a very narrow time window in order to achieve effectiveness. That is thrombolysis within 4.5 hours and thrombectomy within 6 hours. The cardioembolic strokes is 1/3 of all our strokes. And most of the cardioembolic strokes are caused by atrial fibrillation. And in about half of the cases, there is no other concomitant disease. And also in half of the cases, it's de novo cases, not known to have AFib on beforehand. And due to the demographic changes in the Western society, we expect more cardioembolic strokes. In my personal experience, we treat about 500 cardioembolic stroke patients per year in my institution at Aarhus University Hospital. And we are a highly specialized stroke center, which means that we can do MRI scans, thrombectomies, 24 hours, 7 days a week. We have a close collaboration with Skyby Hospital, where our cardiologists are placed. In the community, there is a publication from the Canadian Stroke Registry showing that patients at high risk for stroke with atrial fibrillation and no contraindications for vitamin K antagonists are not treated. Only 10% of their stroke patients were in therapeutic range when they were admitted with a stroke. And even not half of them were in proper treatment. We also have data from the National Stroke Registry in Denmark. It's a high-quality registry. It's mandatory to register your strokes in this registry, and 80% of all strokes are put into this registry. We have audits once a year, and it's made to improve quality of care and treatment for stroke patients in Denmark in general. And you may notice that, is this a pointer? That how to use it? Green? Okay. That most of the patients with atrial fibrillation in this registry is over 80 years. 25% of the cardioembolic strokes were about 80 years. And you can also see that most of them were females, 62% of them. And they were not, they had comorbidities, but not that much. Only 20% of them had high comorbidity index measured with the Carlson comorbidity index. But even though most of them were not treated if they were above 80 years, in the first half year after admittance, only 30% of patients were treated with vitamin K antagonists, and that dropped even further after 1 year to 1.5 years. And in the age group up under 80 years, 60% of the patients were treated, and this is patients that had no contraindications for VKA treatment. So there's a need for a more effective and better treatment for these patients. And then we come to the recurrent stroke. It's 25% of all strokes. And if we struggle to bring down the burden of stroke, we have to focus on recurrent stroke and try to avoid them. Of course, we use the treatments that you also use in cardiology. It's the same. And in this case, in cardioembolic stroke, of course, we have to find effective treatments and to use them. But what we are scared of in neurology is the bleedings. This was published recently and showed that when the warfarin was shown effective for cardioembolic stroke, and it was used in general practice, we also saw an anticoagulation associated intracranial cerebral hemorrhage rate was increasing from 5 to 17% over a 10-year period. And among those older than 80 years, the frequency was almost 50% of the hemorrhage rates were caused by VKI treatment. I also want to point to the fact that it's not the same if you have an ischemic stroke or a hemorrhagic stroke. This is new data, and I see often that you refer to Framingham data where the risk of mortality after cardioembolic stroke is sometimes said to be 50% in the first month. That's not the case in Denmark, at least. I judge the mortality rate after cardioembolic rate with the modern way of treatment to be down to about 15%, not 30%. In general, it's 10%, but if you have a bleed, it's 40% in the first month. And if it's iatrogenic, means that a bleed caused by vitamin K antagonist, it's 50%. So it is serious to get a bleed in your brain. A few comments on the acute treatment. This patient is 64-year-old, and he was admitted after a TIA at our department. He was in aspirin treatment and had warfarin, and his INR was 1.8. And after 12 hours, he had his second stroke event, and at this time it was a massive stroke. We could not treat him with thrombolysis due to the high INR, so we had only one possibility left to do angio and thrombectomy. He had an occlusion of his right intercerebral the right carotid artery. So we had to dilate it and put a stent into this carotid artery before we could come up to brain arteries. But it was successful, and he developed a small infarction the day after the treatment. Now, when we look at his stroke risk, it's around 4%, and his bleeding risk is 1% if we use the scales that we have heard about. We have put him on double platelet inhibition due to the stent in his carotid, but should we also add an all anticoagulation to his treatment? In the guidelines, there's no evidence for treatment within the first 2 weeks, and we have to be aware of an increased risk of hemorrhagic transformation of his acute infarction. But we also know that the restroke or the new emboli come most often in the first few days after a stroke event. So that put together, we just that in this case we should put him on low molecular warfarin heparin, but this was a false decision. He suddenly deteriorated at day 5 and died from bleeding in his brain. Another case to illustrate the difficulty that we have. This is a 71-year-old male with a newly diagnosed AFib 2 weeks ago, but he was not on all anticoagulation at admission. He was admitted 6 hours after the first acute event, and we could not deliver thrombolysis at this point because of the time window has passed for safe treatment. 3 days later he developed a new stroke, and this time it was a massive left hemispheric stroke. We did an acute scan showing that he had only a very small infarction at the time, but we had the subacute infarction in his right hemisphere, and therefore thrombolysis were contraindicated. We could also see the emboli in the main stem of MCA. So we did thrombectomy, and this went smoothly, and the artery was fine afterwards. But at day 2, he was still somnolent, and this was due to a hemorrhagic transformation. And we know that it is common to develop hemorrhagic transformation in patients in the acute phase, especially after cardioembolic strokes, but also in this case when we have recanalized his arteries, it's a successful full case. His adjusted stroke risk is now 7%, and his bleeding risk is 8%. So what should we do? How should we treat him? We planned to treat with dabigatran in the high dose, but to start after 3 weeks, and it went well in this case. Another case, just to remind you that most of the bleedings that we experience in stroke patients is in patients with within the range of 2 to 3 INR, range 2 to 3. And this patient is a patient that had his first stroke in 1995, and at that time it was judged to be caused by his hypertension, and he was treated, and he was well treated for his hypertension. Then he had his AFib in 2006 and got on warfarin, and he suddenly had a headache and left-sided paresis. During the transportation to the hospital, he got comatose, and he died after a few hours. So what is the problem with bleeding in the brain? The problem is that it's not a one-time problem. It continues during the first 24 hours. There is a 40% rebleed risk. And if you're on warfarin, the odds ratio for hematoma expansion is 3 times higher. And adding to that, we have no good and efficient treatments for the patients. Now, in my view, we have better treatment to offer the cardioembolic stroke caused by atrial fibrillation with the new anticoagulants. And they have the same or better prophylaxis compared to warfarin as to new emboli, but we have a problem when they come in with a new ischemic stroke, because we don't know how to measure if it's because they have forgotten to take the medicine, and there's still a 2% risk of having a new ischemic event while you're on the new all anticoagulants. But they are far more better when you look at the bleeding risk. So in our department, it is the first choice for patients with a cardioembolic stroke to use the new all anticoagulants. Why is it that the patients have this high risk of bleeding? There's two main causes. One is hypertension, and the other one is cerebral amyloid angiopathy. This is a case of bleeding on warfarin in a patient with hypertension and AFib. It's located in the basal ganglia, but what we also see in this patient is that there's some microbleeds in the same area. And microbleeds is a warning sign. In some experts' opinion, it should be counted as if it is bleeding. And here's the pictures to illustrate the amyloid angiopathy. They often have lobar bleedings, and when you use MRI, you can see all those small black spots in the brain, in the subcortical regions, and they have a tremendous high bleeding risk. If we have such a patient, we will not even put him on aspirin afterwards. So when can we resume anticoagulation, and when should we stay out of medical treatment for patients? We have no guidelines in this area, but we have experts, and what they have tried to weigh for and against treatment is lined up in this slide. And to end the talk, in my view, we have quite a lot of patients that we should consider for referral to LAA occlusion. Obviously, patients with kidney disease that we cannot put on the new all anticoagulations. We also have the patients with previous intercerebral hemorrhage. We have patients with uncontrolled hypertension and microbleeds, or patients with a diagnosis of cerebral amyloid angiopathy. And we have patients that cannot tolerate the new all anticoagulants due to gastrointestinal problems, or patients with recurrent ischemic strokes on the new anticoagulants. And also there's other reasons. High age, for example, you saw that only 30% of patients above 80 years are treated as it is now, so there's room for improvement. We have compliance problems. If patients forget to take their pills, they will not be protected the day after. And also we have concomitant diseases and patients that need aspirin as well for protection. Yes, so to conclude, cardioembolic stroke is frequent. We see them, you touch them, I think, but the burden is in our departments, and we have the experience. You should collaborate more close with your neurologist, in my opinion, and of course I have to know my cardiologist in order to advise my patients best what they should choose for treatment. I'm so lucky that in my institution we really have a good collaboration with Skyby Hospital, and I think most of you will know. And we have an increasing number of more than of the old patients that in this at this time mostly are not treated. We should focus on them. Can they tolerate the new possibility with the occluder? I don't know if there's much knowledge about it, but we have to stick into it, because every third girl in my generation are expected to get 100 years old. So please find out. Yeah. So, no, I'll end now. Thank you.
Thank you very much.